The learning objective for this lesson is to be able to collate the data from a series of case reports to prepare for applying the Bradford-Hill criteria. So we're going to talk about data gathering. Let's remind ourselves that causality assessment is not just an intellectual exercise. Our aim is to detect signals in order to minimize harm to patients. National centres publish their own signals. Signals from the UMC based on international reports in Vigibase are circulated in this signal publication to the national centres so that they can consider the relevance of the signal to them. In this example, we will look at reports of omeprazole and acute renal failure. This is a known reaction, but it is interesting to see how evidence developed, starting with individual case safety reports. In 1996, a national centre had 3 reports for the first time of omeprazole and acute renal failure, reported since 1994. This is a simple method of regularly screening a database to promptly detect a suspected adverse reaction when it has been reported 3 times. In this series, the reports were for 2 males and 1 female. The ages were from 77 to 78 years. Omeprazole was the sole suspect medicine in all 3 reports. Looking at outcomes, 1 patient died. They had rheumatoid arthritis, and it was thought they might have had rheumatoid vasculitis affecting the kidneys, but there was no evidence for that. In the other 2 reports, there was no evidence for why the patients developed renal failure. 1 patient had not recovered at the time of reporting. For the other one, outcome was unknown. The next step for a national centre is to search its database for any reports for omeprazole in the system organ class urinary tract disorders. There were no other reports of abnormal renal function, but there were 2 reports of interstitial nephritis affecting 2 males aged 59 and 72 years. 1 had symptoms suggesting renal failure, and omeprazole again was the sole suspect in both reports. Time to onset was 8 months and 4 months, and these people had had biopsies. 1 of them had interstitial nephritis and 1 had fibrosis, which was thought possibly to be due to repeated attacks of interstitial nephritis. 1 recovered with sequelae, and for the other, the outcome was unknown. So you might start to ask, well, was interstitial nephritis the cause of the renal failure in the other reports? This is a condition we discussed in the single case report assessment module. The tissue between the functioning parts of the kidney becomes inflamed and swollen, probably due to an immune reaction, and compromises renal function. A literature search is the next step. There was nothing in the product information at that time, but there was a very small number of published case reports of interstitial nephritis and omeprazole since 1992. Was there sufficient evidence that omeprazole caused interstitial nephritis? An examination of the reports in Vigibase to the end of 1995 actually revealed 15 reports of interstitial nephritis with omeprazole, more than were published. Using the UMC-IC method, the number of observed reports was significantly greater than expected, since the IC025 value, the lower border of the credibility interval, was greater than 0. The actual IC value was 2.17 and had been increasing for the previous 3 years, which is also supportive of causality. Data mining, including the IC method, will be discussed in another module. It is important to understand how to search and interpret the data in Vigibase. First, find all the reports for the drug of interest, so search for the drug as a substance. View all the system organ class group. Ensure you find all the reports of the diagnosis. Some people might just have entered nephritis. If it is an important issue, you may want to follow up with the reporting country. On the other hand, be careful not to include conditions that are not relevant. For example, glomerulonephritis is an entirely different condition, and it shouldn't be included. So learning how to search is an important aspect of assessing a case series.